much, Shailesh, Jayesh, and Parimal to involve me. It's a task for me to be pitched after Amrish Mittal sir, and I'll see how I can fulfill this. With an obituary to Dr. Singh. So we as orthopedic surgeons, we have used this for many, many years for assessing hip osteoporosis radiologically, very famously called as Singh and Manya index. And we unfortunately lost Dr. Singh only a few days ago. And that's Dr. Singh, who was settled in Canada in his last days. And that's Singh and Manya index, which is very popular. But of course, we know fragility fractures are extremely common, and these are the statistics which we all know about. But the issue most commonly seen is the statistics, the data, which attracts an orthopedic surgeon because we don't really believe in a lot of numbers. We believe in clinical picture that is seen, and we know from the data that osteoporotic fractures uh, surpass the incidence of heart attack, stroke, and breast cancer even combined. And even with best of the treatment of hip fracture in best of the institute, still the morbidity and mortality is so very high. What we as orthopedic surgeons face is, even though on day one on table we do a fantastic job of fixation, the implants tend to walk out if the if the bone is osteoporotic, and if between the race of fracture healing and fracture fixation, if we are not able to hold the fracture fragments well, the implants would fail and implants would walk out. And there are consequences of vertebral fractures which we see in terms of acute and chronic pain, loss of height and deformity, and of course bad or poor quality of life. Even the consequences of distal radius fracture, which is the very common consequence of pre-existing osteoporosis. And we know that even with again best of the treatment, more than 50% have some amount of morbidity. Of course, with some common treatment modalities, most of the fractures we have been able to hold together. But to my endocrine colleagues, I'm going to show you some ghastly pictures, some good learning pictures, which will take you to the area wherein we you will be able to see some commonly seen failures. There are technical challenges which we as orthopedic surgeons face because we have to hold the fracture together till the fracture heals. Because of osteoporosis, there is huge crushing of especially cancellous bone, creating a lot of void, and thus implants cannot be fixed in that poor quality bone, which results in failure of implants very early on. So that's the task which we face. And so we have some special implants that we tend to consider while fixing these fragility fractures. We tend to do more and more arthroplasty or primary replacement if the fracture is involving a joint. We have certain designed implants which are meant to deal with poor quality bone, like fixed angle locking plates as is written here, or we enamel or we cover the implant with either hydroxyapatite, or we push hydroxyapatite into that void which is created. We tend to use more and more of nails because nails can go within the bone in the medullary canal as against plates which are surface implants. And again, as I told you, we can use to fill the void either cement, which is hydroxyapatite cement, or bone cement, or we can use grafts, and we will see in my next few slides of examples how. So these are fractures which are near the joint, which can be easily considered for arthroplasty. So hip arthroplasty or shoulder arthroplasty, as a primary treatment to avoid failure of implant, and thus we to treat bone, underlying bone, which is osteoporosis affected, is a lesser challenge if we replace the bone to begin with. Of course, there are certain issues also, even though we replace the bone, there are certain issues that we face, and we will see what are those issues. And the issues are peri-implant fracture or a peri-prosthetic fracture. So at the end of implant, the bone can still fracture because it's a poor quality bone. At the end of processes, the bone can still fracture because the ground or the bone is still weak. If there is a pre-existing implant, arthroplasty done, and a fracture proximal or distal to it, we can use a fixed angle locking plate. Now, what does this do? It creates a single mechanical unit. The screw gets locked in the plate. So the plate sits on the bone. The screw goes in the bone and gets locked by independent threads present at the head of the screw into the plate. So the whole thing will act as a single mechanical unit. So if it has to fail, it will not fail at the junction of the fracture. The whole implant has to walk out for it to fail. So it is better for an osteoporotic situation. Or as I suggested, we can cover the implant by hydroxyapatite, which will have a better purchase in the bone. So such implants are now more popular. On the left that you see is a normal implant. On the right you see is a white colored coating, which is hydroxyapatite. Manifestations, we can see fracture. We can vertebral fractures are well known to all of us. We prefer using a intramedullary nail as you see on the left, or a fixed angle construct as you see on the right. If there is a void as is seen here, we can fill that void even with bone morphogenetic proteins, which is the favorite today. Or we can push in the cement inside. If there is a fracture which is a vertebral fracture causing pain, we can distract it by an open method and push a bone cement inside, which is open vertebroplasty. We do see MRI and we do see such ghastly images pressing on the spinal cord, causing huge amount of pain to the patient. Even without compression, these kind of fractures, vertebral fractures, can cause huge amount of pain to the patient. So to combat with the pain, we can do posterior decompression and stabilize the fracture across into one two vertebrae above, one or two vertebrae below, to distract it and reduce the pain. So for vertebral fractures, we can consider vertebroplasty or balloon kyphoplasty, or we can use a bone expander system to do this. Our goal is to give strength to the bone, balance of the patient, and we are looking more and more towards preventing the fall, because the balance also gets distorted of these patients with pre-existing osteoporosis, and we are more and more looking at sarcopenia. So osteosarcopenia is the buzzword amongst orthopedic surgeons, which is directed towards preventing the fall. Let's look at a couple of examples. So this is a patient who had rheumatoid arthritis, very young patient, but see, the patient was dwarf. That's how the patient presented with. On one side, hip arthroplasty, hip replacement was done. On the other side, for some fracture, this fixation was done. Patient started having pain. So the colleague of mine removed one of the screw so as to close this gap of delayed union. Now, because of rheumatoid, patient was already on long-term steroid. See, this screw was removed and the nail broke there. Orthopedic surgeon colleague removed the nail, and look at what the disaster happened. At that stress buster, patient had a fracture. What are the choices to an orthopedic surgeon? Either put a huge implant, arthroplasty, and so the nail was taken out and a hip replacement was done. with lots of grafts been put at that fracture or non-union site. Again, as we always think that arthroplasty done will take away the misery. No, it does not. We will have fracture at the tip of the joint replacement. And so that happened. So what are my options as a surgeon now? Put in a longer rod, a longer hip replacement there, or use a plate there. This is called as Menon plate, which will just cramp the bone along the length, or use a independent plate which will use surclage wires to hold this together. So I used a plate bypassing the fracture, and at this time I also realized that the patient was vitamin D deficient, osteomalacic. Vitamin D was given, teriparatide was given, zoledronic acid was not in the vogue that time, and look the magic that happens. As early as in 12 months, the patient starts throwing callus, and this is 3 years down the line with excellent bone union and patient having no complaints. So we as orthopedic surgeons, we tend to neglect the underlying metabolic bone disease. We have to pay attention to that. So that's tip one. Another patient, this time the patient was a mother of a anesthetist friend, 75 years. Patient had avian of the hip, which required total hip replacement. It was done in January 2017 somewhere else. Post total hip replacement, mother had a falling, having a leading to a fracture, and at that point in time, the patient came to me. So when the patient came to me, patient already had a total hip replacement. Patient had a fall, fracture around total hip replacement, and that's how it is. So if you look at this, the socket is rotated, socket is falling into the pelvic cavity. Surgeon attempted to put a plate there, inadequately fixed, and that's how it came to me. That's how the patient has come to me, 14th of September 2017. That's how the picture looks like. The cup is falling within the pelvic cavity. Fracture is inadequately fixed, not looking good. We did an uncemented total hip replacement with a longer stem using cerclage wiring, preserving the biology at the fracture site. The problem is taken care of. Yes, no. Look what happens. The patient is all right for a couple of months, and then osteoporosis still there. Tip of the process is another fracture. So as Amrish sir was telling, once the fracture, the cycle of events, second fracture, third fracture, fourth fracture, if not adequately treated, the skeleton as a whole will happen. So that's another fracture. That's preoperative X-ray. And this time we had to have a long plate all along the axis of the bone with cerclage wires. So here there is no way we can put in screws there. Cerclage wires done in a biological way to preserve the biology at the fracture non-union site is our favorite in orthopedic world. Wherever we can have, we will put screws to add to the fixation modality, but the key is to span the entire length of the bone so as to avoid the second and third fracture at the tip of the processes. And what will happen next is, this is the way we have to we do it biologically. We don't open the fracture site, we do minimal invasive way, and these are the equipments that we use to put a cerclage wire, and ultimately the fracture will heal in situ without any problems, and the cup is replaced, the fracture is healed well at proximal. So where you have less purchase of bone, what we use is cerclage wires in orthopedic world. Next case, that's a fracture again at the tip of the bone. Again, the entire length of the bone we put a plate, and wherever we cannot put the screw or screw will have less purchase, we tend to use cerclage wires. And that's 4 months down the line. Preserve the biology using cerclage wires. Use as long as implant as possible, intramedullary processes or extramedullary plate. try to span the entire length of the bone. So that's what we do. Another quick example, a typical fracture following bisphosphonates. So that's a very known area where patients will have this kind of a fracture following long-term bisphosphonates without holiday. Surgeons will fix this with this kind of an implant, not preferred. We want to use an intramedullary nail in such a situation to have a better purchase. um, Again, when we see non-union and this kind of implants, watch what happens. The implants will back off, and the second fracture, the patient also has osteoarthritis of the knee, rheumatoid patient, the screws will come out leading to a fracture there. Stress risers in this pre-existing osteoporosis is very common. What do I do? Fracture there, already osteoarthritic knee, do a total hip replacement to combat that fracture neck of femur and bypass the fracture which was there. Look what will happen. This is a short implant. Replace the knee as well. So that's how it looks. Total hip at the top, total knee at the bottom. Patient very good. Corona lockdown, and patient had another fracture at the tip of processes. So we have to look for these. So again, what I did was a long plate bypassing the fracture site. So multiple fractures, as has been emphasized earlier, is extremely common. We have to keep watching at the end of the implant for stress razor, because eventually they will fracture. So the last case, that's the fracture, tip of the implant, periprosthetic fractures, osteoporosis, extremely common. Again, a long plate, throwing in cerclage wires to hold the fracture sites, preserving the biology, and this time adding biology by doing this. What you see there is a live vascular fibular graft, preferred way. A live graft, fibular vascular graft, even with difficult osteoporosis, has yielded us a better outcome. So bone grafting helps. Fibular stud graft is a good option. So throwing in biology, in addition to, of course, medical management later on, has rescued us orthopedic surgeons out of difficult situations many a times. So to conclude, fractures are common and fractures will be more common. Osteoporotic fractures are associated with increased morbidity and mortality, and we are also looking at prevention of falls now. Fracture is among the strong risk factors, and we don't have to really wait for BMD to be done. Once there is a fracture, that's an indicator for us orthopedic surgeons that the patient is already classified as a severe osteoporotic patient, and we can immediately institute medical management. And as Mittal sir has rightly suggested, most of orthopedic surgeons, trauma surgeons, find this as an opportunity to pump in zoledronic acid when the patient gets admitted with us. Most of the fear of orthopedic surgeons is gone now, because initial reports suggested some cardiovascular impact when patients were still admitted with us. That fear is gone. So most of us orthopedic surgeons, we give zoledronic acid to have that peace of mind, at least for subsequent immediately occurring within 6 months fractures. And effective treatment, of course, then is given by endocrine colleagues. Thank you very much. Thanks for patient listening.